Thank you very much, Owen, and thank you for coming today. I'm going to touch on some of the stuff Leslie touched on as well, mainly because medication for PoTS seemed a little narrow, and so I broadened to treatment. The lesson is I might have to ask to go first next time, but we'll see. So, and the reason is because I think it's a mistake to dissociate medication from the other treatments for PoTS. I mean, the reality is that we do recommend exercise to everyone, and we can touch on some of the questions that were asked about perhaps the foolishness of some of the recommendations. I would argue that rowing actually works for a lot of the patients, and there are strategies for that. And then, as Leslie said, the strategies for drugs actually move across a couple of areas. There are different approaches we take to increasing blood volume, and that's based on a fair number of studies, some of which we did at Vanderbilt, some were done at other centers, showing that the majority, not all, but the majority of PoTS patients, when formally assessed, actually have a low blood volume. So that seems like a reasonable rationale to target. Then we'll talk about some of the hemodynamic agents that I think we think of as PoTS drugs a little more often, and then a word on behavioral therapies, and there's going to be a session on that, so it's not going to be not very many words anyway. So the reality of exercise in PoTS is that I don't know that we ever thought it was a bad idea. Early, say 15 years ago, my clinic at Vanderbilt went something like this. The patient would come in, and in the end we'd say, well, you should exercise, because as a cardiologist, that's what we're trained to tell people to do. The patients would say, you don't understand, doctor. If I try and do this, I can't get out of bed for 2 days. And we left with this sort of, sense of balance. I did what I thought I needed to do. They weren't going to do it. We both knew it. We moved on. Now, the challenge is that, there are some patients that did exercise, and over time when you saw them, they seemed to do better, right? But even then, chicken or egg, right? Was the exercise making them better, or was that just a declaration they weren't as sick to begin with, right? And we had no way of teasing that out. And that's until about 10 years ago when there were a few studies that came out, but probably the best one came out of Dallas, showing that exercise training assessed in the same, with good assessments in the patients before and after a program showed improvement. And this was a heroic study led by Chi Fu and Ben Levine in Dallas. And I swear, if you can think of something they should have assessed, they probably did, right? They looked at physiology, they looked at hormones, they looked at traditional autonomic testing, they looked at orthostatic tachycardia, they looked at simple quality of life. They used the SF-36, which has been used in probably every disorder known to man, before and after, right? So they looked at how the patients felt, how the physiology improved, they did cardiac MRIs, echoes, they put catheters in and measured pressures. And they put people through what they called a 3-month program that actually took 6 months for most people to complete. So a 3 to 6 month exercise program, and showed improvement. And they found that it improved lots of things. It improved fitness levels, increased blood volume, improved cardiac remodeling. A lot of these patients, as Dr. Dietary said, have higher levels of sympathetic tone or hyperadrenergic. It decreased that with direct nerve recordings. None of these things patients cared about. But it decreased the orthostatic tachycardia and improved their symptoms, which patients do care about. So it's fine to say, okay, go forth and exercise. In that study, they had these detailed calendars. They had people yelling at the patients if they didn't show up, right? So there was an expectation that you show up at this time on a certain day. They had trainers. I have none of that, right? So I had to modify this. Now, the truth is, if you want, you can actually get these calendars online. The problem is I don't understand the calendars, right? The calendars speak exercise physiology. They're very detailed. I have no idea what they're saying, right? So I don't tend to use them, but if you have a trainer that likes to speak exercise physiology and wants them, they're available, right? But I've tried to take what they did and crystallize it into underlying principles, and they are here. The first key is that this is primarily an aerobic reconditioning program. It's not exclusively an aerobic reconditioning program. They actually want 2 days of some resistance training focused on the thighs a week, but it's primarily an aerobic reconditioning activity. And this is important because a lot of patients exercising with some of the other disorders, chronic fatigue and fibromyalgia, will come and tell me about the bicep curls that they're doing with their trainer and their 2 minutes of aerobic training, or they'll tell me about their Pilates. And don't get me wrong, my wife has started doing Pilates. I don't think I could do this without falling. right? It's hard to do, good core strengthening, but that's an and, not an or, right? That's not going to in and of itself help your PoTS. It may help you with lots of other things. The PoTS training is aerobic. It has to be regular, right? So you have patients saying, well, they're exercising 1 or 2 days a week, and if they were to ask, is it really, is that really not better than doing nothing? The answer is, of course not. 1 to 2 days a week probably is better than doing nothing. But for the training benefit, it has to be regular, and regular means every other day. Right, so realistically, what that means is a lot of patients will try to target, say, 6 days a week, recognizing that that doesn't happen usually. But even if they miss a day or two here, they're still getting 4 days a week. Now, in the program itself, where they had these calendars, if you missed a day or two, they pushed you back 2 weeks in the calendar. This is one of the reasons why this 3-month program took 5 or 6 months to complete. Now, I thought this was just because they were asses. But it turns out, and people can quibble about whether, anyway, it turns out that if you talk to patients my patients that have gone through this, if they miss a couple of days, for whatever reason, they're traveling, they get sick, what they tell me is when they get back to the gym, they're not able to do quite as much as they were able to do even a few days before. Right, so there is an acute loss of conditioning that can occur. Not it all goes away, but you sort of lose a step fairly quickly. So the 4 days a week is critical if you want this training benefit. And the sessions have to be very quickly 30-minute sessions. So people talk a lot about gradual training, graded training, and all that. Time is critical. And I'll tell you, this is why in the point below, no upright exercises, rowing machines are what they liked. And the person that asked the question about it being a tough aerobic activity, the reason it was chosen probably is because the Dallas group actually is an exercise physiology group who've studied high-performance athletes as well, and they thought that rowers have among the greatest aerobic capacity with the rowing machine. Right, but recumbent cycles are okay, swimming is okay. The truth is in Calgary, there's not a lot of outdoor swimming for 10 months of the year, right? So you're restricted to indoor pools, so we don't tend to use that very much. But I don't like it for another reason. And that is that with the rowing machine and the recumbent cycle, there are exactly 2 inputs, right? I prioritize time. So to do that, I tell people when they start the rowing machine to turn the resistance dial all the way down. Effectively, I want no resistance in the system. And I want them to do 30 minutes. Now, realistically, people will come back to me later and say, well, I'm up to 12 minutes. So what I tell people is that if at 12 minutes you feel like you're about to die, you feel like you're sort of, your vision's going, you feel absolutely miserable, they don't need to go to 30 minutes because Dr. Raj said 30, gotta keep going. They're done, right? At 12 minutes if they're done, they're done. But they messed up. They did it wrong. Because there are only 2 inputs, as I said. One is resistance. If they turn that off, the only other input is speed. And if they can only do 12 minutes, they went too fast for them. Now, it's possible their husband, most of my patients are female, may think that if they go any slower, they'll be going in reverse, right? It doesn't really matter. It doesn't matter what anyone else thinks you're doing. The reality is, if you can't do 30 minutes, you went too fast to do 30 minutes. And slow it right down. And you can get to 30 minutes. And as you do this, they'll want to speed up. They will speed up over time. They'll want to add resistance over time. They can do that when they want. The key is to get to 30 minutes 4 times a week. And as Leslie said, it can take a while to see any benefit. And this is really critical, I think, to mention to patients. I'll tell you the problem, I think, with exercise prescriptions. They're prescribed by evangelists. Not Christian evangelists, like exercise evangelists, right? People go around talking about how the grass is greener, the sky is bluer, the world smells better, there's this runner's high. Clearly I should exercise more than I do, but I'll tell you, I've never found this runner's high. I've smacked into the wall. The high is on the other side of the wall, right? If you go and tell these patients that can barely get out of bed and barely get to clinic without feeling like crap, that if they exercise, they're going to feel better, and they go and do it and they can't get out of bed at all, you will lose all credibility. Tell them how crappy they will feel. Tell them how miserable they'll feel. But tell them that'll end at some point. That point is actually, unfortunately, 4 to 6 weeks later, right? You have to, I would not do something for 6 weeks unless someone told me that I'd feel miserable that long. I might give it 2 weeks if I like the person, and then stop. Right? So part of our problem with this is I don't think we've actually laid out the expectations properly. We have to reframe that to a great extent. Okay, so that's exercise. Blood volume strategies. So Leslie talked about water. We tend to recommend 3 liters of water, but why quibble? The reality is these are all well below the danger level. We push salt aggressively. I'm a bigger fan of diet rather than tablets, mainly because of tolerability and or price. For the ones that are well tolerated are really expensive, and the ones that aren't really expensive are not well tolerated, at least the ones we have. I tend to try and get people up to 2 teaspoons a day. Now the question is how you do that, right? So most people, including me, couldn't actually measure out the amount of salt that I take in. I'm not fastidious enough to look at the labels and add up all those milligrams of sodium. Right, so what I tell people to do is to take a teaspoon of salt to start in the morning and to put it in a little Ziploc snack bag. Apologize if the Ziploc brand isn't popular here. You can pick any snack bag. The Sainsbury brand will work just as well. And then their job is to get that in them through the day. And I really don't care how, right? So for most patients, that involves adding it to their food, however they want. I have one patient that likes to add it to hot water with some lemon and drink it. When she tells me this, I sort of feel nauseated and I think I'm going to vomit. But it works for her, right? And it doesn't matter if I feel like nauseated. As long as she can do it, that's what matters. I have one patient that actually just tells me they'd rather just spoon it in their mouth and sort of chomp on the salt like in that cartoon. Whatever works, right? So the target dose is 2 teaspoons for me. And that provides, each teaspoon, depending on how generous it is probably 2 to 2.5 grams of sodium, right? So 2 of those is 4 to 5, double that for sodium chloride, give or take. You're looking at the 8 to 10 grams that we talk about, right? That's a lot of salt, but it can be done. And the other advantage of the Ziploc approach is that when people start this, they can get a sense of how much they were taking in. Because if they're done by 11 in the morning and they're wondering where the rest of the salt is, they were well over that. Conversely, if it's 7 or 8 p.m. and they have 3/4 of the bag left, they weren't even close to getting in the amount of salt that we want them to get in. Right? But salt is important to retain the water. It's an important part of the strategy. In my mind, it's crazy and potentially almost malpractice to start putting people on fludrocortisone without telling them to increase their dietary salt intake. And we do see that, unfortunately. I'm not going to talk about octreotide in any great depth, but it has been looked at. IV saline is sometimes used in DDAVP. What I'll say about salt is that we've sort of done it as an article of faith for a long time, but we actually do have some data that, unfortunately, I have to actually write up to publish, but it's been presented in abstract form. We brought people into a research unit at Vanderbilt and put them on a low salt or high salt diet for a week and then assess them. And when we say assess them, we looked at blood volume formally using sort of nuclear medicine techniques, norepinephrine levels lying and standing, some similar data to what you've seen, and orthostatic vitals. These are the 2 groups. We did this for PoTS patients and for healthy control subjects. Sodiums were similar between the groups as expected. Blood volume was lower in the PoTS group than the control group. That's something that we fairly consistently found. And what we found was that high salt diet actually normalized the blood volume deficit in PoTS patients. And it super normalized it, I guess, in control subjects. And if you looked at the orthostatic tachycardia, it decreased the standing tachycardia and decreased the delta tachycardia in the PoTS patients and to a lesser extent in the healthy control subjects. And similarly with plasma norepinephrine. What I will say, though, is it didn't normalize the patients. Interestingly, the high salt diet made, 300 milliequivalents of sodium, which is a lot of salt, a lot of sodium in the diet, made a PoTS patient look like a healthy control subject on a really low sodium diet. Right, so it didn't sort of make the patients entirely like the controls, but it sort of shifted them along the way. And so it clearly does do something, if not being the whole story. And that's just what I said. I probably should pay attention to my slides better. Octreotide, so this is fairly old data from Robert Holtke in West Virginia. Octreotide is a peptide, right? It's a bit of a pain in the butt because you have to jab, you have to keep it in the fridge, you have to jab, it's like insulin in that way. But when absolutely desperate, it can be effective in both lowering the orthostatic tachycardia in PoTS patients and improving symptoms, but also in improving blood pressure and orthostatic hypotension in autonomic failure patients. We don't tend to use this a lot because of the level of difficulty, so I'm not recommending this widely, but as you're starting to get desperate and Nick won't see your patient for 6 months, these are things that you can at least talk to him about and sort of see if you can get started, maybe. IV saline works. Right? There is data that intravenous saline, a liter, will decrease the orthostatic tachycardia. This is an old study from Vanderbilt before I got there in the late 90s. Acutely, the liter rescues the phenotype. Enough so that I recommend this to patients when they're in the emergency room feeling miserable and someone's trying to figure out whether they need to be admitted or not. I usually recommend a liter or even 2 liters of saline as a trial before making that decision. Most patients will improve enough that they don't need to be admitted. The problem is when you repeat it. So IV saline acutely can be delivered through a peripheral intravenous line. If you keep doing it, the veins go, and eventually, at least in North America, you go down this slippery slope to a PICC line and then a central line. And the problem, in our view, has always been central lines, and this is why the Heart Rhythm Society has had this as a class 3 indication. It's not the saline, it's the access. And this study was from a pediatric group at Children's National in Washington, showing that for reasons that I don't fully understand, the complication rate in the PoTS patients was actually higher than in the rest of their patients. A lot of the rest of their patients were oncology patients, but it was higher and the complications aren't trivial. There's a more recent report from Blair Grubb's group in Toledo where they had a bunch of patients receive saline and they said, hey, you know, a bunch of them got weaned off and we didn't have all these complications. But the majority of these patients never got a central line. So this group, a lot of the patients really were on it for just a couple of months. I still hesitate to advocate this, but what I will say is if you have a patient that wants this and you're prepared to consider it, before you start, have an exit strategy, right? The question for the patient is, fine, we can do this for a short while. What are you going to do so you change and you don't need this 2 months from now? Because the patients will feel better acutely with it. And it's going to be tough 2 months later to say, okay, you're done, right? Unless they've done something else to make themselves better. DDAVP, this is desmopressin, used for little kids that wet their bed. So how bad can it be? Promotes free water retention in the kidney. And it lowers orthostatic heart rates and tachycardia in PoTS patients. We show that acutely. The concern with desmopressin is that we don't tell kids that wet their bed to drink 3 liters of water a day, right? So there's a real risk of hyponatremia if uncontrolled. I've used this as a special event drug. Someone wants to go to a movie on Thursday night with their friends, they're not sure how they'll feel. They take this sort of later in the afternoon, they'll usually have some blood volume expansion that lasts for several hours. Blair Grubb's group in Toledo has actually taken to giving this to people nightly, and they have a desmopressin clinic that's like a Coumadin clinic, right, where they weekly have their sodiums checked and sent in. Their nurses look at it to make sure the sodium's okay. What I heard from Blair is that this has worked well except for one patient who thought that if 0.2 of desmopressin, if 1 tablet is good, 4 tablets will be so much better. And she got hyponatremia, but everyone else tolerated it quite well. So at the dose of 0.2 a day, it seems to be safe. Still, check the sodium. Hemodynamic agents, mitidrine can work. It decreases the tachycardia a little bit. This was the same study as the saline study I showed you before. So while the saline halved the orthostatic tachycardia, the mitidrine took the edge off a little, right? So it helps, but its effect is more modest. Beta blockers, as a cardiologist, I had a preceptor from New Zealand who said if it moves, beta block it, right? He was very aggressive. We sort of don't like heart rates that go up at all after a heart attack. The problem is that, there are a lot of patients that report intolerance to beta blockers, and there's some acute data suggesting it doesn't improve symptoms. So we studied this when we were at Vanderbilt with our acute study, and the interesting thing is a lot of these patients in the study said, I don't do well with beta blockers, and we said, okay, we'll give it to you anyway, and they said, okay. And the propranolol usually won. 20 milligrams of propranolol acutely, short-acting propranolol. And importantly, in addition to hemodynamics, it improved symptoms. Right? This is an acute orthostatic symptom rating scale we developed at Vanderbilt that we used in this and other studies. The question was why? And the credit for this observation goes to our long-term research nurse at Vanderbilt named Bonnie Black, who pointed out that because PoTS patients tend to be sensitive to drugs, we tend to give a low dose of drugs when we test these things out. So we said, okay, so we added a high dose propranolol, so in addition to the 20 milligrams and 80 milligrams for a period of time. And what we found is that while the 80 milligrams of propranolol lowered the heart rate and blood pressure even more than the 20, the symptom benefits started to regress. Right? So a little bit of propranolol to take the edge off the heart rate increase, good. Too much propranolol to normalize the heart rate, bad. Right? Mainly because people feel worse. I can normalize anyone's heart rate, give it enough beta blocker. The problem is that most of these patients will not want to get out of bed if you do that. We did some work with acetylcholinesterase inhibition with mestinon or pyridostigmine. So the rationale was that this works to increase synaptic acetylcholine at the autonomic ganglia, which would help both the sympathetic and parasympathetic nervous system, but also in the parasympathetic nervous system alone, from a heart rate point of view, in the vagus alone, it'll lower heart rate, right? So figured 2 parasympathetic, 1 sympathetic, maybe it'd be a good thing. And we were able to show a benefit. It's sort of a smart drug. It did improve symptoms and lower heart rate. The truth is it's not a very potent drug, right? So in the real world, if you just use this, you don't get much benefit. But in combination with beta blockers, it seems to work well, except when it doesn't. I don't have this here, sorry. So Blair Grubb's group published a series of 300 clinic patients where they gave it. About 50 to 60% reported some vague sense of benefit. That's good. 20% didn't tolerate it. Not so good. Almost all of that was due to diarrhea and abdominal cramping, right? So if you have IBS patients that are prone to diarrhea, avoid it. If you have patients prone to constipation, this may be the best thing they've ever had, right? I use this drug for constipation more than I do for heart rate, right? It's a great bowel drug, although the GI people never seem to prescribe it because it's a neurology drug, but works wonders. Ivabradine, if you go to the web, this seems to be the wonder drug for actually most things. The bottom line is there's no randomized data in PoTS patients. There is a randomized trial in inappropriate sinus tachycardia. There are some case series. A lot of that data actually is from the UK, suggesting some benefit. It's not a wonder drug, right? So there is some benefit. The main side effect is sort of vision changes. It's all reversible, so may well be worth trying. We actually have some funding. We've just received funding from Dysautonomy International to try and start a comparative head-to-head trial between that and propranolol and placebo. So we'll see how that works. Norepinephrine transport inhibitors. Who's prescribed norepinephrine transport inhibitors? Yeah, the rest of you are lying. I suspect that most of you have, right? So this is actually a really common component of a lot of the neuropsych drugs. So any SNRI drugs, the N is norepinephrine transport inhibition. The purest version in Europe is reboxetine, which has gotten a bad rap for different reasons as an antidepressant. But Effexor, Wellbutrin, Cymbalta, I don't know if the brand names translate or not. Lots of the sexy psychiatric drugs proudly tell you they block the norepinephrine transporter. Right, so we looked at atomoxetine, which is the purest version we had in North America, and this increased standing heart rate, increased seated heart rate, increased orthostatic tachycardia, and made symptoms worse. It's the only drug that we ever tested that made symptoms worse. It's the only drug that raised heart rate. If you look at our placebo data, placebo lowers heart rate because of diurnal variability in the way we do our tests. This went against that trend. I would be wary about using this drug, any drugs in this class in patients. Now the truth is, PoTS isn't a thing. It's a bunch of things. It's heterogeneous. When we looked at the symptom burden, 2/3 of the patients got worse. 1/3 didn't. Some had no change in symptoms. A few actually improved on it. Right? So there's different subgroups, but as a general rule, it's the only drug overall that we had symptoms worsening with. I've thrown this in, IVIG as emerging therapy. We heard a lot about this from Valeria, in terms of different things it could be used for. There's a lot of interest in autoantibodies. There is one study suggesting that over time there are a bunch of patients that respond. What I'll say is not only is there no randomized data, it's hard to look at that initial study and figure out how my patient would fit into that study. This was done by a person that sees autoimmune disorders in everyone that comes to clinic. She may be right. Maybe we all have autoimmune disorders and we'd all benefit from IVIG. We should wait and see. There is a study that's run by Steve Vernino right now, funded by Dysautonomia International, to look at IVIG in PoTS patients with some other autoimmune disorder. So that may provide the first bit of data for this. This is from that study showing a symptom improvement over time. So this is a summary of recommendations from the Canadian Cardiovascular Society position statement that Nick alluded to. We recommend that everyone partake of non-pharmacological therapies. So if there are medicines that may be making things worse, diuretics, for example, norepinephrine transport inhibitors, for example, please stop them. We're big fans of salt and water. I refer to it as pickling our patients. They start understanding what I'm talking about after a while. Big fans of lower body compression. I haven't included the data, but I have a master's student who has presented abstracts looking at segmental compression, and there's a very nice dose-response relationship in terms of tilt-induced heart rate and the amount of the patient that we compress in terms of abdomen, legs, or both, right? It can be very effective therapy. It may be, the issue might be finding sort of a suitable method of compression commercially, but very effective for those in need. Exercise training is very strongly recommended. And in terms of drugs, there's reasonably good data for mitogen and propranolol. Again, not in everyone. You have to sort of pick and choose a little who gets it. Less good data for pyridostigmine, fluticcortisone, ivabradine. And for those patients that really seem to have a lot of heart rate and blood pressure, Valeria sort of referred to this hyperadrenergic phenotype. I'm not sure, I don't like the term hyperadrenergic PoTS for different reasons, but there are people that are hyperadrenergic. Central sympatholytic drugs like methyl-dopa, clonidine can sometimes be very effective when used carefully and gingerly. And finally, with saline, I think there's a weak evidence in favor of using it acutely, but evidence against using it chronically, again, dealing mainly with access issues and not the salt or the water issues. So we came up with a treatment algorithm, mainly because we were told we had to, putting it down, but we thought that you could sort of try and tailor therapy based on what the dominant symptom is. So although I'm a big fan of propranolol, if someone's standing heart rate is only 110, even though they met the 30-beat criteria, my anecdotal experience is they don't do phenomenally well with propranolol. But if their standing heart rate is 140 beats a minute, then dropping that a little bit can often afford a huge benefit to symptoms. So if tachycardia is a dominant symptom, propranolol may be a good place to start. If they tend to have really soft blood pressure, they walk in, their pressure is 85, their heart rate doesn't go up a ton, then squishing them with mitogen may well be a good place to start. If they're really hypovolemic, you can start with fluticcortisone, but when I say start with fluticcortisone, I mean after you've sort of pickled them, right? So after the salt and water. It's not an or, it's an and. And then for those few patients, and it really is rare, that are really, really revved up and hyperadrenergic, then methyl-dopa or clonidine. So methyl-dopa has a longer half-life. It's smoother, that's why we use it. We don't have clonidine patches in Canada, although I'm told that you have them here. Clonidine patches can probably do the same thing, but clonidine pills tend to cause their own set of problems. Just too short a half-life, too many ups and downs. Okay, so don't forget the non-pharmacologic stuff. And I apparently have a lot of circles I forgot about, so it's all blown up here if you need to see it. I don't know if you're getting these slides anyway or not, but quite possibly, according to Leslie. Okay, final word on behavioral therapies. And I have, I think, 30 seconds to do it, but there'll be another talk on it. I'm basically a human physiologist by training and a cardiology person. And my focus had always been to try and understand the why and figure out if we can fix the why with drugs or by doing other things. And it was actually a patient, had this patient with recurrent syncope that would torment me. Because she fainted a lot, she was miserable, she'd come to clinic and berate me for the fact that she fainted a lot and I wasn't making it better. And you could sort of look at the clinic list and sort of gird yourself that this afternoon was going to be miserable for me because she was coming, and I sort of had this whole psychological preparation for me. The problem is she worked at Vanderbilt, and so outside of clinic she would sometimes accost me when I was least expecting it. And that was psychologically traumatic for me. So there was one day when I was walking to my, if I'd see her, I'd actually sort of turn the other way so she wouldn't see me. But there's one day I was walking to my car, across the quad, and she saw me and called out, so it was too late for me to escape. And she came up to me, and something was wrong. She was smiling. This is like the first time ever I'd seen her smiling, right? So, I knew there's something was amiss. And she told me that her family doctor, her primary care physician, had started her on sertraline, or Zoloft. And there's a whole serotonin hypothesis and syncope, and so I said, oh, so you're fainting less now? And she said, no, I'm still fainting. It just doesn't bother me as much. And I thought, great. And I went to my car thinking, man, that was crazy. But the more I thought about it, actually, that was actually probably one of the more insightful interactions I've ever had. Because what I wasn't paying attention to was the fact that while all these patients I was seeing had abnormal physiology that I was trying to correct, they all had a chronic illness. They had to live with this one way or the other. And some patients did that better than others. And ultimately, until they figured out how to live with their chronic illness, they were going to be miserable. Now, this isn't to say that everyone should be on Zoloft, right? The truth is, there are probably different approaches that work for different people, right? This is where sort of the mindfulness stuff comes in. Personally, I wish I had discovered those adult coloring books, right? It seems like a brilliant idea that I could have thought of, but I didn't, right? Tons of money in it, right? Some people like yoga, some people go to religion. It doesn't really matter to me what approach they take, but they need to take an approach to learn to deal with their chronic illness. Patients, not just doctors, patients often ask the question, is this in my mind or in my body? Right? They're asking, is it real? And the truth is, that's the wrong question, and you need to point them in the right direction. Okay, so I'm about to get pulled off the stage, so the take-home messages are that it's a chronic disorder, it's a syndrome, it's not one thing, and that means the treatments may not all be uniform. It may vary from person to person a little bit. But the underlying principles of treatment are the same and involve the same 4 categories. And with that, coffee is available. Oh.